Okay, usually when we sit down for these deep dives, we take a topic and just, explore it for the pure joy of learning, following curiosity wherever it leads. But today is different. Today isn't just a deep dive. It is a full-blown tactical prep session.
Right.
We are stepping into the shoes of a senior MD anesthesia faculty member preparing a resident, that's you, the listener, for the high-stakes Gujarat University MD exams.
That's absolutely right. And we aren't just skimming the surface here. We are tackling a topic that is absolute gold for examiners.
Oh, really?
It really is.
Yeah.
It's the topic that separates the technicians from the true physiologist physicians. We are analyzing fetal circulation and fetal-maternal transfer of drugs with anesthetic implications.
Okay, so this is high-yield must-know material. I've been looking at the question banks, Gujarat University, DNB, the works, and this stuff is everywhere.
It is.
I mean, December 2008, December 2014, it feels like it's on there practically every other year. We're talking theory questions, short notes, and I can only imagine it is an absolute minefield in the Viva.
It is the ultimate test of clinical reasoning. As an external examiner, and that's the mindset I'm bringing to this conversation today, I love this topic.
Why is that?
Because it forces you to integrate basic anatomy, fluid dynamics, pharmacology, and crisis management all at once. If you can't explain how a single molecule of, say, thiopentone gets from the mother's vein to the fetal brain, and more importantly, why it might get stuck there, you aren't ready to be a consultant.
That's a high bar. So here is the roadmap for this session for everyone listening.
Let's lay it out. We
are going to deconstruct the anatomy of fetal circulation, and we're going way beyond just saying blood goes round and round.
Oh, much deeper than that.
We'll analyze the violent hemodynamic transition that happens at birth. We'll look at the placenta as a sieve rather than a true barrier.
A very important distinction.
Then we'll cover the physics of drug transfer, the slightly terrifying concept of ion trapping, and finally, a drug-by-drug breakdown of what we use.
And we will wrap it all up with specific exam gold, how to structure your answer, what diagrams to draw, and the specific phrases that get you those distinction marks.
Perfect. Let's start with part A, the context, or, the exam framing. Why is this such a big deal for us as anesthetists? Why not just leave this to the pediatricians?
It's a great question, and it's the fundamental why. It's because the pediatrician only meets the baby after the cord is cut.
Right, after the fact.
For the 9 months prior. And crucially, during any surgery or delivery, the anesthetist is the only doctor in the room treating 2 patients simultaneously. You have the mother, your primary patient, and you have the passenger.
The passenger, I like that.
Exactly. And they are connected by this one incredible organ, the placenta. Residents often make the mistake of treating the placenta like it's a brick wall.
I put the drug in the mother, it stays in the mother.
Exactly that thinking.
Yeah.
And it is completely wrong. It's an imperfect, highly complex interface. Every single time you push a plunger, you are medicating 2 organisms with vastly different physiologies.
Which means you have to understand both.
You have to. So let's get into that physiology. Part B, fetal circulation. If you don't understand the plumbing, you can't possibly understand the pharmacology.
So where do we start?
The fundamental concept you need to open your theory answer with, the one that frames everything else, is this. Fetal circulation is a parallel circuit.
Parallel, okay. As opposed to our adult circulation, which is in series.
Correct.
Okay.
In you and me, the right ventricle pumps blood to the lungs, that blood returns to the left atrium, and then the left ventricle pumps it out to the body. It's sequential. One pump after the other in a single line.
A series circuit.
Yes. But in the fetus, that system is impossible. And why is it impossible?
Because the lungs aren't working yet.
They're not working at all. They're essentially solid organs. They're fluid-filled, they're collapsed, and they offer tremendous resistance to blood flow. You can't pump the entire cardiac output through them.
So the ventricles have to work together somehow to pump into the systemic circulation at the same time.
Yes. They work in parallel. And this brings up the first major exam nuance, a detail that shows you've really thought about it. Right ventricular dominance.
Okay, that's counterintuitive. In the adult, the left ventricle is the king. It's the thick, muscular powerhouse.
It is. But in the fetus, the right ventricle actually does the heavy lifting. It ejects about 2/3 of the combined ventricular output, with the LV handling only about 1/3.
Wow. Okay, why? What's driving that?
Resistance. It's all about the physics governing the flow. In the fetus, pulmonary vascular resistance, what we call PVR, is incredibly high.
The brick wall we just talked about.
The brick wall. The pulmonary vessels are physically crushed by the fluid-filled alveoli, and there's a powerful hypoxic vasoconstriction going on. It's a very high-pressure system to pump against.
And on the other side of the equation, the systemic circulation.
Systemic vascular resistance, or SVR, is incredibly low. And why do you think that is?
It has to be the placenta.
It is the placenta. The placenta is this massive, low-resistance vascular bed. It's like opening a huge tap. It's a giant sump that just sucks blood towards it.
So blood naturally flows away from the high-resistance lungs.
And towards the low-resistance placenta. That's the fundamental gradient.
High PVR, low SVR. That gradient drives absolutely everything. But for the blood to actually bypass the lungs, we need some kind of workaround. We need shunts, the admixture.
We do. And describing these shunts is where you really pick up points in an exam. But don't just list them. That's what a textbook does. You need to explain their function. Why are they there?
Okay, so let's walk through the actual path of a single red blood cell. Let's start it at the placenta.
The perfect starting point. The placenta is the fetal lung. It's the organ of respiration, nutrition, and waste disposal. And crucially, it receives a massive amount of blood, about 40 to 50% of the total fetal cardiac output.
So our red cell picks up oxygen there. Then where?
It travels up the umbilical vein. And for your Viva, you must emphasize the singular, one vein.
One vein, two arteries. Got it. And this umbilical vein carries the most highly oxygenated blood in the entire fetus, right?
It does, but here's another nuance. The saturation is only around 80%, and the PO2 is only about 30 to 35 millimeters of mercury.
That sounds terrifyingly low. An adult would be profoundly cyanotic.
They would, but the fetus has fetal hemoglobin, HbF, and HbF has a massive affinity for oxygen. It binds it and holds onto it very, very tightly. So that 80% saturation is perfectly adequate.
Okay, so this super oxygenated blood travels up the umbilical vein and it hits the liver. This must be where we find shunt number 1.
This is the Ductus venosus. Think about it. The liver is a metabolic furnace. If all that fresh, oxygenated blood had to filter slowly through the liver sinusoids, the hepatocytes would just gobble up all the oxygen before it ever got to the heart or the brain.
So the fetus needs a bypass. An expressway.
An expressway is the perfect term. The ductus venosus is a high-velocity pipe that shoots about half of that umbilical blood straight through the liver and into the inferior vena cava, the IVC.
It's not just a simple pipe, though, is it? I remember reading something about a sphincter mechanism.
Ah, a crucial detail for a distinction-level answer.
Yeah.
Yes. There is a physiological sphincter at the umbilical end of the ductus venosus.
And what's its purpose?
It's a protective mechanism. It protects the fetal heart from sudden volume overload. Imagine a powerful uterine contraction that squeezes a huge bolus of blood from the placenta up the umbilical vein.
Right.
Without that sphincter, that surge would hit the fetal right atrium and could cause acute heart failure. The sphincter tightens, it constricts, and it dampens that pressure wave. It's a beautiful piece of natural engineering.
Very clever. So now our highly oxygenated blood is in the IVC, mixed with some deoxygenated blood from the lower body.
Yeah.
And it all enters the right atrium.
And here's where the real magic happens. This is the concept of preferential streaming. Examiners absolutely love this concept.
Because it explains how the most important organs get the best blood supply.
It explains everything. It explains why the fetal brain develops so well, despite the relatively hypoxic environment. You have two distinct streams of blood entering the right atrium that, remarkably, barely mix.
Okay, break them down for us. Stream number 1.
Stream 1 is our hero stream. It's the high-velocity, oxygen-rich blood coming up the IVC from the ductus venosus. It's moving faster than the rest of the blood.
And where does it go in the right atrium?
It hits a specific structure on the interatrial septum called the crista dividens. This acts like a rudder on a boat. It directs this fast-moving stream straight across the right atrium and pushes it through shunt number 2, the foramen oval.
The foramen oval,
Yeah.
the hole between the right and left atria, so it bypasses the right ventricle completely.
It completely bypasses the right ventricle and the entire pulmonary circulation. The path is RA, straight through the foramen oval, into the LA, then down to the left ventricle and out the ascending aorta.
And the very first branches off the ascending aorta are the coronary arteries and the carotid arteries.
Exactly. The heart and the brain get the stream 1 champagne blood, the purest, most oxygenated blood available in the fetus. The vital organs are prioritized.
Brilliant. So what about the rest of the body? What happens to the deoxygenated blood?
That's stream 2. This is the deoxygenated blood returning from the head and upper limbs via the superior vena cava, the SVC.
Okay.
It enters the right atrium as well, but because of its angle of entry and lower velocity, it misses that express lane to the foramen oval. Instead, it gets directed downwards through the tricuspid valve and into the right ventricle.
So this is the blue blood, and it's getting pumped by the dominant right ventricle towards the lungs.
It enters the main pulmonary artery, but remember our brick wall, the PVR is sky high, so only a tiny fraction, maybe 5 to 10% of that blood, actually goes into the lungs to perfuse them.
So where does the other 90% go?
It takes the path of least resistance. It flows through shunt number 3, the final piece of the puzzle.
Yeah.
The ductus arteriosus.
Which is the connection between the pulmonary artery and the descending aorta.
Correct. So this deoxygenated blood completely bypasses the lungs and gets shunted directly into the aorta, but, and this is key, it joins the aorta after the arteries to the head and heart have already branched off.
I see. So the lower body, the gut, the kidneys, the legs, receives this mixed, slightly more hypoxic blood.
Exactly. And that blood then flows down to the internal iliac arteries, which give rise to the 2 umbilical arteries, sending it all back to the placenta to get cleaned up and start the cycle again.
Okay, let's connect this to our practice. What's the direct anesthetic relevance of this complex streaming?
It's massive. If you cause maternal hypotension, say from a spinal anesthetic, or if the uterus contracts too hard and squeezes the maternal spiral arteries, you are directly reducing the flow in that umbilical vein.
You're cutting off the supply to stream 1.
You are starving stream 1. You are starving the fetal brain and the fetal heart of their high-octane fuel. Every decision we make that affects maternal blood pressure has an immediate and direct consequence on fetal brain oxygenation.
That raises the stakes significantly. It makes you think twice about every intervention.
It should.
Okay, so that's the system in utero. Now let's talk about the moment that changes absolutely everything. Birth. The transition.
It is, without a doubt, the most dangerous physiological event in any of our lives. It's a complete and violent reversal of hemodynamics that has to happen perfectly within seconds.
2 things happen at almost the same time, right? The cord is clamped, and the baby takes its first breath.
They happen simultaneously, but let's separate them to understand the effects. First, the cord clamp.
What does that do?
You are clamping the umbilical cord. You have just physically removed the placenta from the circulation. You've removed that massive, low-resistance circuit.
You've closed the big tap.
You've closed the tap. Instantly, systemic vascular resistance, the SVR, skyrockets. It basically doubles.
Yeah.
The left ventricle, for the first time in its life, suddenly has a massive axial load, a huge pressure to pump against.
Okay, so SVR goes way up. Now, the breath.
The baby gasps. That first breath creates a huge negative intrathoracic pressure, which helps to physically pull the lungs open.
Right.
But the most important thing is that oxygen floods the alveoli for the first time. And that oxygen is a potent pulmonary vasodilator. It directly reverses that hypoxic vasoconstriction we talked about.
So the brick wall crumbles.
The brick wall crumbles. The PVR, the pulmonary vascular resistance, plummets dramatically.
Okay, so let me get this straight. In a matter of seconds, the SVR has doubled and the PVR has plummeted.
Yeah.
The entire pressure gradient has flipped.
It was completely flipped. Before birth, the pressure on the right side of the heart was higher than the left. Now, with high SVR and low PVR, the pressure on the left side of the heart is much, much higher than the right.
And this pressure change must be what closes the shunts.
Instantly, the now high pressure in the left atrium physically slams the flap valve of the foramen ovale shut against the atrial septum. It's like a door being blown shut by a strong draft. Functional closure is immediate. Anatomical fusion takes weeks or months, but the door is closed.
What about the 2 ducts, the ductus arteriosus first?
The ductus arteriosus is sensitive to 2 main things: oxygen and prostaglandins. The rising PA2 from breathing directly causes the smooth muscle in the wall of the ductus to constrict.
Okay.
At the same time, the placenta was the main source of prostaglandins, specifically PGE2, which are potent vasodilators that actively kept the ductus open in utero.
So when you remove the placenta,
The prostaglandin levels drop, the keep open signal is gone, and the close now signal from the oxygen is strong. So the duct constricts and closes functionally within hours to days.
and the ductus venosus.
That one's simpler. It closes passively. Once you clamp the cord, there's no more flow coming up the umbilical vein. No flow, no function. The sphincter constricts, and it fibroses over a week or 2 to become the ligamentum venosum.
This all sounds so perfect, but it can go wrong. This leads to a critical anesthetic implication, the concept of persistent fetal circulation.
Yes, or persistent pulmonary hypertension of the newborn. This is the nightmare scenario. If the newborn baby gets hypoxic or acidotic or, and this is absolutely crucial for us in the operating theater, hypothermic, that whole process can reverse.
How so?
Hypoxia and acidosis are powerful pulmonary vasoconstrictors. They can cause the PVR to shoot back up. The pressures can flip back to the fetal state. The right-sided pressure becomes higher than the left again.
And the shunts reopen.
The foramen oval and the ductus arteriosus can pop back open. But now there's no placenta to oxygenate the blood.
So the baby is just shunting deoxygenated blood from the right side to the left side.
And pumping it straight to the brain and body. You enter a death spiral of hypoxia causing more shunting, which causes more hypoxia. It's a catastrophic vicious cycle.
And this is why we are so obsessive about keeping the baby warm during a C-section.
This is exactly why. A cold baby is a baby at high risk of reverting to fetal circulation. Temperature control isn't just about comfort. It's about preventing a life-threatening hemodynamic collapse.
That covers the anatomy and the transition beautifully. An amazing system. Let's shift gears and move to Part C, fetal-maternal transfer of drugs. We established that the placenta isn't a wall.
Right. In your exam answer, you should never call it a barrier. A much better term is a semi-permeable lipid membrane, or a metabolically active interface.
Okay, so what is its structure?
Structurally, it's a hemocorial placenta,
Right.
which is a fancy way of saying that maternal blood is in direct contact with the fetal chorionic villi. The maternal blood literally bathes the fetal tissue.
So the distance for diffusion must be tiny.
It's incredibly small, about 2 to 4 microns by the end of pregnancy. And it actually gets thinner as the pregnancy progresses, which makes transfer even more efficient.
So how do our drugs get across this interface? What are the mechanisms?
By far the most common, the most important mechanism for virtually all of our anesthetic drugs is simple diffusion.
Simple diffusion, it just follows a concentration gradient.
Exactly. It follows Fick's law of diffusion. You should be able to state this in your exam.
Okay, let's break down Fick's law for the listeners in a practical way.
Sure. Fick's law says that the rate of transfer, how quickly a drug moves across, is proportional to a few things. First, the concentration gradient. The more drug you have on the mother's side, the faster it will move across.
Makes sense. What else?
It's also proportional to the surface area of the placenta. A bigger placenta means more transfer, and critically, to the lipid solubility of the drug.
We'll come back to that one. So what is it inversely proportional to? What slows it down?
Two main things. The thickness of the membrane. A thicker membrane means slower transfer, and the molecular weight of the drug. Bigger, heavier molecules move more slowly.
So that's simple diffusion. What are the other less common mechanisms?
Well, there's facilitated diffusion. This still follows a concentration gradient, but it needs a carrier protein to help the molecule across. The classic example is glucose. The fetus needs a lot of glucose, more than simple diffusion can provide.
So it has a helper. No energy required, though.
No energy. That's the key difference with active transport. This process uses energy, ATP, to pump substances against their concentration gradient.
Like what?
Things the fetus needs to accumulate, like amino acids for building proteins, or certain vitamins and minerals like calcium.
Okay. And there are a couple of others, right?
Yes, there's pinocytosis, which is basically cell drinking. The cell membrane engulfs a droplet of fluid containing the substance. This is how large molecules like maternal immunoglobulins, e.g., get across to provide passive immunity to the fetus.
And finally, there can just be breaks or leaks in the membrane, I suppose.
Exactly. Breaks in the villi can lead to direct mixing of maternal and fetal blood. This is rare, but it's the mechanism behind things like Rh sensitization.
Okay, so let's go back to simple diffusion, since that's the most relevant for us. Let's really hammer down the factors that affect drug transfer. If I'm a drug molecule, what credentials do I need to get across the placenta?
Okay, this is a list you must have memorized for your exam. There are 4, maybe 5 key properties. Number 1, molecular weight.
Okay, is there a cutoff?
The magic number to remember is 500 Daltons. If your molecular weight is less than 500 Daltons, you will cross easily. If it's over 1,000 Daltons, you will cross very poorly, if at all.
And where do our drugs fit in?
Almost all of our common anesthetic drugs, propofol, thiopentone, lidocaine, fentanyl, the volatile agents, are well under 500 Daltons. They get an easy pass.
So who are the heavyweights that get stopped at the border?
The classic examples are insulin, heparin, and its reversal agent, protamine. And the big one for us, as we'll discuss, is the muscle relaxants.
Got it. Okay, property number 2.
Lipid solubility. This is probably the most important one. The placenta is essentially a lipid sandwich. The membranes are lipid bilayers.
And like dissolves like?
Exactly. Highly lipophilic or fat-soluble. Drugs cross with incredible speed. They essentially teleport across the membrane. Think of thiopentone, fentanyl, and all the inhalational agents.
Okay. Number 3. This is one that always trips people up. Ionization.
It can be tricky, but the rule is simple. You must remember this rule. Only the non-ionized or uncharged form of a drug can cross a lipid membrane.
Why is that?
The ionized or charged form is water-soluble, not lipid-soluble. It gets repelled by the lipid membrane. It effectively bounces off.
So whether a drug is ionized or not depends on its own properties and the environment it's in.
Precisely. It depends on the pKi of the drug, which is a fixed property, and the pH of the blood it's in. This is going to be very important when we talk about ion trapping.
I'm sure it is. Okay, and finally, property number 4.
Protein binding. A drug that is bound to a protein, usually albumin, is effectively part of a giant complex. It's like a tiny person holding onto a huge boulder.
It's too big to get through the door.
It's way too big.
No.
So only the free, unbound fraction of a drug is available to diffuse across the placenta.
And there's a clinical nuance here for pregnancy, isn't there?
A very important one for exams. Maternal albumin levels actually drop during pregnancy because of hemodilution. This means for many drugs that are highly protein-bound, the free fraction actually increases.
So more of the drug is active and available to cross to the fetus?
That's exactly right.
Okay, so we've got the rules of transfer. Now let's talk about the specific phenomenon that examiners love to ask about. The exception that proves the rule. Ion trapping. I've seen this asked as a standalone short note question.
It's a classic, and it's a beautiful integration of physiology and pharmacology.
So set the scene for us.
Okay. Imagine the placenta is a border crossing. On the maternal side of the border, the country has a pH of 7.4 U. It's slightly alkaline.
Right.
On the fetal side of the border, the country is naturally a little more acidic. Its pH is around 7.3 to 7.35.
Okay, a slight pH gradient.
Now along comes our drug. Let's use a local anesthetic like lidocaine or an opioid. These drugs are chemically classified as weak bases. In the mother's slightly alkaline blood, pH 7.4, a significant portion of the lidocaine molecules will be in their non-ionized, uncharged form. They're lipid-soluble. They're like ghosts that can walk through walls.
So they have a visa to cross the border.
They do. They drift effortlessly across the placental membrane and into the fetal circulation.
But now the lidocaine molecule is in a different country. It's in the fetus.
It's in the more acidic fetal blood. Now, what do bases do in an acidic environment?
They accept a proton, an H+ ion.
They do. And by accepting that proton, the lidocaine molecule becomes ionized. It becomes charged.
The ghost becomes a solid object.
Perfect analogy. It's no longer lipid-soluble. Its visa is revoked. It tries to go back across the border to the mother, but it gets bounced off the lipid membrane.
So the drug can get in, but it can't get out.
It cannot leave. It is trapped. And as more non-ionized drug diffuses in from the mother, it keeps getting converted to the ionized form in the fetus and accumulates to very high concentrations. This is ion trapping.
And this must get much, much worse if the fetus is already in trouble.
Now you're thinking like an anesthetist. What happens in fetal distress?
You get hypoxia, anaerobic metabolism, acidosis, the fetal pH plummets.
Exactly. The fetal pH might drop to 7.2 or 7.1. The fetal country becomes even more acidic. This makes the ion trap incredibly efficient.
So you get a massive accumulation of local anesthetic right when the fetus is most vulnerable.
A massive accumulation. And what do high levels of local anesthetics do to the heart?
They're cardiotoxic. They cause myocardial depression and bradycardia.
Exactly. You get cardiac depression, CNS depression, and the classic floppy baby syndrome at birth. All because of this elegant but dangerous physicochemical trap.
So the clinical takeaway is if we have a CTG showing a distressed acidotic fetus, we need to be extremely careful with our dosing of amide local anesthetics like bupivacaine or lidocaine.
Extremely careful. This is also why an older drug, chloroprocaine, sometimes comes up in these discussions. It's an ester local anesthetic. It gets metabolized so rapidly by plasma esterases in the mother's blood that almost none of it ever reaches the placenta. It doesn't have time to get trapped.
That's a brilliant explanation. Okay, that gives us the principles. Let's move to part D and apply them to our specific anesthetic drugs. Let's run through the drugs on our part, starting with the inhalational agents.
Okay. Sevoflurane, isoflurane, desflurane, nitrous oxide, what are their properties?
They're small molecules, highly lipid-soluble.
So they will cross the placenta rapidly. There's almost no barrier to them at all. The fetal alveolar concentration quickly matches the maternal one.
Is that a problem for the baby?
It can be. At high doses, say greater than 1 MAC, they will cause dose-dependent depression of the fetal myocardium and central nervous system. The baby can be a bit slow to start, But usually by the time we finish the surgery and wake the mother up, the baby has breathed it all off fairly quickly.
So what's the bigger issue with volatiles in obstetrics?
The bigger issue is their effect on the uterus. All volatile agents are potent uterine relaxants. They inhibit myometrial contraction.
And that can cause postpartum hemorrhage. A boggy uterus.
A boggy atonic uterus that bleeds profusely. This is a major cause of maternal morbidity.
So what's the standard practice to avoid this?
We keep the concentration low. We try to use 0.5 to maybe 0.75 MSC supplemented with opioids or other agents. Or a very common practice is to shut the volatile agent off completely as soon as the baby is delivered and the cord is clamped, and then switch to an intravenous technique like a propofol infusion while giving lots of oxytocin.
Okay, speaking of propofol, let's talk about the MV induction agents.
Thiopentone and propofol, again, both are highly lipophilic small molecules. They cross instantly.
So a fair question is, why isn't the baby completely anesthetized for hours after we give the mother an induction dose?
It's a great question. The answer, in one word, is redistribution. The drug crosses rapidly and achieves a high concentration in the fetal vessel-rich organs, like the brain and heart. But then, just as in the adult, it quickly redistributes to muscle, and then more slowly to fat. Also, the fetal liver is surprisingly competent at metabolizing some of these drugs.
So the peak effect in the fetal brain is very transient.
Very transient. The baby might be a little bit drowsy at 1 minute of life, which can affect the APGAR score, but they generally wake up very quickly.
What about ketamine?
Ketamine also crosses readily. The unique thing about ketamine is that it tends to increase uterine tone, unlike the volatiles. This can be useful if the mother is bleeding, but it can also potentially reduce placental blood flow if used in high doses. It's used, but with caution.
And benzodiazepines, midazolam.
The safe exam answer is to avoid them. They cross easily. They cause prolonged neonatal hypotonia, poor feeding reflexes, and impaired thermoregulation. It's sometimes called floppy infant syndrome.
So if the mother is extremely anxious,
Talk to her. Reassure her. If you absolutely must use something, use the tiniest possible dose. But in an exam, the safest and best answer is benzodiazepines should be avoided if possible.
okay, let's move on to opioids. This feels like a minefield.
It can be. Let's start with the basics. Morphine is relatively hydrophilic, but its protein binding is quite low, so a significant amount does cross over time. Fentanyl is very lipophilic, so it crosses very fast.
What about remifentanil? That one's interesting.
Remifentanil is the really interesting one. It's lipophilic, so it crosses to the fetus. But, and this is a key point, the fetus has non-specific esteroses in its blood and tissues.
So the baby can metabolize the remifentanil itself.
Yes, the fetus can break it down very, very rapidly. This means it doesn't accumulate, and its effects are very short-lived. This makes it a very attractive option for obstetric anesthesia, for example, in a patient-controlled analgesia pump.
Okay, but there's one opioid that is a classic exam trap, pethidine, or meperidine as it's known in the U.S.
Pethidine, the old obstetric favorite that has now become the villain of the story. Pethidine itself crosses the placenta. But the real problem is its active metabolite, norpethidine. Norpethidine is a neurotoxin. It's a proconvulsant. It can cause seizures in the neonate.
And it must have a long half-life in the baby.
A very long half-life, up to 60 hours. The fetus and neonate have immature kidneys, and norpethidine relies on renal excretion, so it just builds up and up.
So if you write in your 2024 exam answer that pethidine is the drug of choice for labor analgesia,
You will definitely lose marks.
Yeah.
You can mention that it was used historically, or perhaps for treating postspinal shivering, but you must acknowledge the significant risks of norpethidine accumulation.
that's a very clear warning. Okay, now for what you called the most important drug class for the exam, the muscle relaxants.
This is the exception that proves all the rules we just discussed. Succinthonium, rocuronium, vecuronium, atracurium, all of them. Chemically, they are quaternary ammonium compounds.
Okay, break down the chemistry for us. What does that mean in practical terms?
It means they have a fixed positive charge. They are fully ionized at all physiological pH levels. They're also relatively large molecules, and they are highly water-soluble, not lipid-soluble.
So they fail every single test for crossing the placenta.
They fail every single test. They are bulky, they are charged, they are not lipid-soluble. The result is that they do not cross the placenta in any clinically significant amount.
So let's be crystal clear. The mother is fully paralyzed for the intubation, but the baby is still moving around inside.
Absolutely. The fetus is not paralyzed during a general anesthetic for a C-section. This is a definitive Viva answer. If the baby comes out floppy, it's not because of the rocuronium you gave the mother. It's because of the propofol or the opioids, or most likely because of hypoxia or acidosis.
That is a critical point. What about the reversal agents, neostigmine and glycopyrrolate?
Same principle applies. Neostigmine is also a quaternary ammonium compound. It has a charge. It does not cross the placenta.
Okay, but what do we pair it with to prevent bradycardia, atropine or glycopyrrolate?
This is a fantastic Viva question. Atropine is a tertiary amine. It is not charged. It is lipid-soluble. It crosses the placenta readily and can cause fetal tachycardia, which can confuse the interpretation of the FHR trace.
Like glycopyrrolate.
Glycopyrrolate is a quaternary ammonium compound, just like the muscle relaxants. It is charged. It does not cross the placenta.
So if you reverse the mother with neostigmine and atropine.
The neostigmine stays in the mother, but the atropine goes to both the mother and the baby. You get a tachycardic baby. Therefore, in obstetrics, the preferred combination is neostigmine plus glycopyrrolate. Neither crosses the placenta. It's a much cleaner, more elegant technique.
That is a fantastic clinical pearl. Let's touch on one more class of drugs, vasopressors. Maternal hypotension after a spinal is common and it's bad for the baby. We need to treat it. The old debate was ephedrine versus phenylephrine. Has that debate been settled?
For the purposes of your exam, yes, it has been settled. The old teaching was that ephedrine was best because it was thought to preserve uterine blood flow better. The new teaching, and the correct exam answer, is that phenylephrine is the first-line agent.
And what's the reasoning for that switch?
Two main reasons. Ephedrine is a mixed alpha and beta agonist, and it crosses the placenta easily. It can stimulate the fetal metabolism, making the fetus burn more oxygen and glucose. This was shown to be associated with a lower fetal pH, or fetal acidosis.
And phenylephrine?
Phenylephrine is a pure alpha agonist. It causes potent maternal vasoconstriction, which fixes the blood pressure very effectively. It does not cross the placenta as readily, and most importantly, it has been shown in large trials to be associated with a better fetal acid-base status compared to ephedrine. So phenylephrine is safer for fetal pH.
Okay, that's very clear. Let's move into Part E, broader clinical and anesthetic implications. Let's talk about the scary topic of teratogenicity.
Right. A teratogen is any agent that can cause a structural or functional abnormality in the fetus. The timing of exposure is everything.
What's the critical period?
The critical period is the period of organogenesis, which is roughly from day 15 to day 60 after conception. This is when all the major organ systems are being formed.
And what about exposure before that?
Before day 15, during the blastocyst stage, it's thought to be an all or none effect. Either the exposure is lethal to the embryo, or the embryo survives and repairs itself completely with no lasting damage.
So which of our anesthetic drugs are proven human teratogens?
This is reassuring, actually. Surprisingly few. There's some theoretical concern about nitrous oxide because it inhibits methionine synthase, which is involved in DNA synthesis. It's teratogenic in rats at high doses, but the human data is very weak and inconclusive.
What about the benzodiazepines?
There was an association suggested in some older studies between first-trimester diazepam use and cleft palate. But again, the data is controversial and not definitive. The general advice is still to avoid them if possible, just to be safe.
So what's the big no-no drug in pregnancy?
The big one to remember for your exam is NSAIDs, non-steroidal anti-inflammatory drugs, especially in the third trimester.
Okay, why NSAIDs like ketorolac or diclofenac?
Because they are potent inhibitors of prostaglandin synthesis. And what do we know prostaglandins do in the fetus?
They keep the ductus arteriosus open.
They keep it patent. So if you give an NSI to a pregnant woman late in pregnancy, you risk causing premature closure of the ductus in utero.
And that would be catastrophic.
It would cause acute pulmonary hypertension and right heart failure in the fetus. It's strictly contraindicated.
Okay, so what about the drugs we consider safe?
Most of our standard drugs, propofol, thiopentone, the volatiles, opioids, muscle relaxants, local anesthetics, are generally considered safe when used for necessary surgery. They fall into FDA category B or C.
What's the rule of thumb for surgery during pregnancy?
The rule is to avoid it if you can. If it's elective surgery, defer it until after delivery. If it's urgent, the safest time is generally considered to be the second trimester, after organogenesis is complete, but before the uterus is so large that it causes significant physiological changes.
Let's talk about some of those maternal physiological effects on the fetus, specifically something we as anesthetists control directly, hyperventilation. We get a bit nervous, we're bagging the patient before intubation, and we bag a bit too hard. Why is that a bad idea?
It's a very bad idea for two distinct reasons. When you hyperventilate the mother, you lower her PaCO2, you make her hypocapnic.
Okay. What's the first consequence of that?
First, hypocarbia itself is a potent vasoconstrictor of the uterine arteries, so you are actively squeezing the blood supply line to the placenta.
You're reducing uterine blood flow. Not good. What's the second reason?
The second reason is a bit more subtle. It's the Bohr effect. Lowering the PaCO2 makes a mother's blood more alkaline. This respiratory alkalosis shifts the oxygen-hemoglobin dissociation curve to the left.
The left shift. I remember this from physiology.
And a left shift means that the hemoglobin binds to oxygen more tightly. It has a higher affinity.
So the mother's hemoglobin picks up oxygen fine in her lungs, but it refuses to release it to the fetus at the placenta.
It holds on to it greedily. So even if the mother is well oxygenated, less oxygen is actually transferred to the baby. It's a double whammy. Less blood flow, and the blood that does get there gives up less oxygen.
So what's the goal for ventilation?
The goal is to maintain normal capnia. But remember, normal PaCO2 for a pregnant woman at term is lower than for a non-pregnant person. It's around 30 to 32 millimeters of mercury, not 40. So you aim for that. Do not aggressively hyperventilate.
That's a crucial, practical point. Okay, let's pull all this together. Part F, exam integration. We need to help the listener structure this information for their written paper and their viva. Let's start by constructing the mental tables they should have ready to go.
Excellent idea. These are the frameworks for your answer. Table 1, fetal versus adult circulation.
Okay, what are the key rows in this table?
Row 1, resistance. For fetal, you write high PVR, low SVR. For adult, you write low PVR, high SVR.
Row 2, gas exchange.
Fetal is placenta. Adult is lungs. Simple.
Row 3, shunts.
Fetal had 3. Ductus venosus, foramen ovale, ductus arteriosus. Adult has none. They've become ligaments.
In the final row?
Ventricular relationship. Fetal is parallel. Adult is series. If you can lay that out, you've shown you understand the core principles.
Okay, perfect. Now, table 2, placental transfer of common anesthetic drugs. Let's do 2 columns. High transfer versus low or no transfer.
Good. In your high transfer column, you must list thiopentone, propofol, all volatile agents, all opioids, local anesthetics, and atropine.
And in the low or no transfer column, the exceptions.
This is the money column. You must list all muscle relaxants, succinylcholine and the non-depolarizers, glycopyrrolate, neostigmine, heparin, and insulin.
If you can just reproduce those 2 tables from memory in the exam, you're already halfway to a pass on this question.
Absolutely. Provides a perfect structure.
Okay, now let's role-play some common viva traps. I'll be the skeptical external examiner. You be the well-prepared candidate.
Let's do it.
Candidate, you've just done a C-section under GA, and the baby has come out a bit flat. The surgeon asks you if it was the muscle relaxant you gave. What do you say?
Sir, it is highly unlikely to be the muscle relaxant. Drugs like rocuronium are quaternary ammonium compounds. They are fully ionized and do not cross the placenta in clinically significant doses. The neonatal hypotonia is more likely due to other factors such as the effects of inhalational agents, opioids, or potentially fetal acidosis from a compromised uteral placental circulation.
Very good. Next question. Candidate, you tell me that local anesthetics can harm a distressed fetus. What is the precise mechanism for this?
Sir, the mechanism is ion trapping. Fetal distress leads to acidosis, which lowers the fetal pH. Local anesthetics are weak bases. They cross the placenta in their non-ionized form, but become ionized in the acidic fetal environment. This charged form cannot cross back to the mother, and therefore accumulates in the fetal circulation, leading to cardiotoxicity.
Excellent. You used the key phrases. Okay, last one. Candidate, I see you are using lipid emulsion for local anesthetic systemic toxicity in the mother. Does this treatment help the fetus at all?
Sir, the primary goal of lipid emulsion therapy is maternal resuscitation. By restoring maternal cardiac output and blood pressure, we restore uteral placental perfusion, which is the most critical intervention for the fetus. There is a theoretical benefit that the lipid sink created in the maternal blood could create a concentration gradient to pull local anesthetic back from the fetus, but the priority and proven benefit is in treating the mother.
Perfect. Those are safe, intelligent answers. Now let's talk about diagrams. They say a picture is worth 1,000 words. In an exam, it's worth at least 5 marks. How should they draw the fetal circulation?
Don't just draw a circle with arrows. Be systematic. Start at the bottom of your page and draw the placenta as a box.
Okay.
Draw the single umbilical vein going up towards the liver. Show the ductus venosus as a clear bypass channel through the liver into the IVC. And draw the heart as a big box with 4 clear chambers.
What's the most important part of a heart diagram?
Showing the shunts in action. Draw an arrow going directly from the RA to the LA through the foramen oval, and draw the pulmonary artery giving off a large branch, the ductus arteriosus, that connects to the aorta.
Any pro tips to make the diagram stand out?
Yes. Use 2 different colors if you can, or at least use shading, to show oxygenated versus deoxygenated blood. And this is the tip that gets you the distinction labeled the approximate oxygen saturations at key points. Put 80% on the umbilical vein, put maybe 65% on the ascending aorta going to the brain, and put 55–60% on the descending aorta. Examiners love to see the numbers. It shows a deeper understanding.
That is fantastic advice. It shows you're not just memorizing, you're understanding the physiology. Okay, we're nearing the end. Let's summarize the absolute key high-yield bullet points for the exam. The final revision list.
Let's do it.
Fetal circulation is a parallel circuit with high PVR and low SVR, designed to spare the lungs and perfuse the brain via preferential streaming.
2. The placenta is a semi-permeable, metabolically active sieve, not a solid wall.
3. The transition at birth is a dramatic pressure flip. PVR plummets, SVR skyrockets, and the shunts close.
4. Drug transfer is primarily by simple diffusion and is governed by molecular weight, protein binding, and most importantly, lipid solubility and ionization.
5. Ion trapping is the accumulation of weak bases like local anesthetics in an acidic fetus, leading to toxicity.
6. Muscle relaxants are ionized, do not cross the placenta, and do not paralyze the fetus. This is non-negotiable.
And finally, 7. The prime directive of the obstetric anesthetist is to protect maternal blood pressure, to protect fetal blood flow. Everything else follows from that.
That is a perfect summary. As we wrap up, what's a final provocative thought to leave our listeners with as they head into their exams? Something beyond the syllabus.
Well, we spend this entire session talking about how to prevent drugs from getting from the mother to the fetus. But there is a fascinating cutting-edge frontier of fetal surgery called exec procedures.
Ex utero intrapartum treatment.
Exactly. These are procedures where a surgeon will operate on the baby while it is partially delivered but still attached to the placenta via the umbilical cord.
So the placenta is still acting as the lungs.
Yes. And in these cases, our entire goal flips. We deliberately anesthetize the mother specifically to anesthetize the fetus for the surgery. We want maximal placental transfer. We use high-dose volatile agents to provide deep anesthesia to the fetus, and just as importantly, to produce profound uterine relaxation to stop the uterus from contracting and expelling the baby.
So the imperfect barrier suddenly becomes our primary drug delivery system.
It flips the entire script on its head. It shows that a deep understanding of these principles doesn't just help you pass exams, it allows you to participate in the future of medicine.
That is a brilliant place to end. But for now, for everyone listening, focus on the basics we've covered today. Visualize that stream of blood, visualize that trap of ions.
You absolutely have the knowledge now. Go into that exam with confidence. Go ace that paper.
Good luck with the Gujarat University exams. We'll see you on the next deep dive.